So obstructed venous drainage. So when you're comparing these three syndromes, you just really want to understand, the basics of some of the anatomy, and that will kind of help you interpret what's going on. Because a lot of the times you have to understand where the mass is or where the thrombosis is happening. So let's just start off with superior vena cava syndrome. And I know I already kind of put a question on this in one of the videos, but the concept here is there's some mass lesion. Usually it's a malignancy. It could be a mediastinal tumor that's in the superior vena cava. It could be a thrombosis. If you have a venous catheter or an intravascular device like a dialysis catheter, or we talked about pacemaker wires already, if those are in the venous system for a long time, they can clot. And the longer they're there, the higher risk they become. And these patients, if you have a patient with superior vena cava syndrome, you're knocking out this area here. You're going to have some clot here, or you'll have some mass here. And so you're going to have impaired venous drainage back into the right atrium. So everything proximal is going to kind of build up. And so you will see edema usually in the bilateral face, right? Because you're affecting both sides of a backup of blood flow. Okay. And then you also can see it in the bilateral extremities for the same reason. Classically, jugular venous distension, and these patients eventually can develop increases in intracranial pressure. They can have papilledema, headache, plethora, and that's because also you have your jugular veins here that are also draining into this venous system, and you're blocking everything so far upstream that you're affecting multiple areas. But when you have a brachiocephalic venous obstruction, so if it was more of a classic one for brachiocephalic obstruction would be like a Pancoast tumor. Now, it's not pathognomonic. You can have tumors also blocking the SVC, but classically, if you had a Pancoast tumor, let's use a darker. So if I had a Pancoast tumor like here, right, and a Pancoast tumor, remember, that's an apical lung tumor. So if I had a Pancoast tumor here, I'd be blocking off the brachiocephalic vein. But look, it's different than if I blocked off the subclavian, because now I still have patency on this side, right? On my patient's left, I still have patency. It's on the right side that I'm blocking the venous drainage now. So I would have ipsilateral impaired jugular venous drainage, right? So I might have JVD on one side, and the patients will also usually have edema only localized to one side of the face. Same thing is true for the upper extremities. Remember, in board questions, everything is usually classic. So it's usually going to be the unilateral face, unilateral upper extremity. Of course, in real life, right, there might be some exceptions to that. And the last thing here is if I go even further distally, if I have a mass over in the subclavian vein. Now, the subclavian vein is going to come off a little bit further down here. So if I had a mass back here in the subclavian vein, again, I'm only affecting one side, but the difference from the brachiocephalic obstruction is that I'm not affecting the jugular venous system this time. These veins can still drain, right? The mass is over here, so I'm just going to have impaired venous drainage in the unilateral upper extremity, typically no facial involvement because I don't have impaired drainage here. Now, the other situation that can come up is an inferior vena cava compression. This is very classic in a pregnant female, usually third trimester. Since it's more of a obstetric gynecology kind of question, it comes up more on step 2, but the way it comes up on step 1 is because you have to know the anatomy. Again, it turns into an anatomy question again. So if the mass is at the inferior vena cava, where's the edema going to be? Where am I going to have a backflow of blood? Probably in the bilateral lower extremities, right? Because I'm blocking off all of the flow coming back to the right atrium. And fetal hypoxia can also occur because we have this backflow of blood, right? We have decreased preload now because I'm not bringing blood back to the heart. That's going to decrease cardiac output. You get placental insufficiency and fetal hypoxia. Okay, so that's the general concept. Why does this even happen in pregnant women in the third trimester? Well, you can imagine the uterus, when you have a gravid uterus and it's grown to a pretty significant size by the third trimester, it can start to put pressure on the inferior vena cava. It can also put pressure on the aorta, right? Because it can push down on these structures and kind of pinch down. And you might be saying, well, does it affect the aorta the same way? Not really. It mostly affects the inferior vena cava because the pressures in the inferior vena cava are so much lower than in the aorta. And so for that reason, this tends to be affected first. And the thing about supine hypotensive syndrome, where it gets its name, is when mom is supine, that's when the uterus is going to, with the effects of gravity, is going to push down on the inferior vena cava the most. Okay, and so in these situations, that's when they tend to experience hypotension or tend to experience dizziness or lightheadedness. Kind of the opposite of what you would expect to see with like an orthostatic hypotension, which would be far more common overall. And the other thing is, if you do see a third trimester pregnant female on your first rotation or something like that, and she has edema, don't assume that she has inferior vena cava compression. I mean, it's possible she might, but more than likely, a pregnant female in the third trimester is retaining sodium and water, which we'll talk about more in a future video, that's contributing to the edema. The edema is not a rare finding in pregnancy, is what I'm trying to say.